Hi, I'm Jade Marcilla.
Hi, I'm Tavia Solomon.
And I'm Ashton Sawatsky, and the topic we'll be discussing today is non-small cell lung cancer under the concept of cellular regulation. Cisplatin is the pharmacological intervention we'll be presenting on. Cells are the microscopic structural and functional units that build and maintain life. Cellular regulation is what allows a cell to stay within homeostatic limits. This is through the intracellular response to extracellular signaling from hormones and neurotransmitters. When individual cells stop properly functioning, they are removed through programmed pathways. The attributes of cellular regulation are proliferation and differentiation. Proliferation is the cell's process of growth and division, thereby creating new cells. Differentiation is the process by which a less specialized cell develops a distinct function and form. However, these processes can go wrong. Two genes particularly responsible for these processes are proto-oncogenes, which promote growth, and tumor suppressor genes, which suppress growth. When a cell experiences multiple genetic mutations in an order over time, this can result in uncontrolled proliferation and lack of differentiation. Neoplasms, or tumors, are what we call this uncontrolled growth. They can be cancerous or benign. Lung cancer, the most preventable cancer, claims the greatest percentage of lives of men and women in Canada per year of any cancer. Although lung cancer pathophysiology is not completely understood, it is thought that repeated carcinogen exposure, such as to cigarette smoke, causes metaplasia, leading to lung epithelium dysplasia with repeated exposure. Hypersecretion and non-specific inflammatory changes follow. Continued exposure to carcinogens can result in genetic mutations. The mutations most commonly responsible for non-small cell cancers are those that occur to the KRAS, P16, and EGFR. These mutations cause an array of effects as tumor suppression is inhibited and proliferation occurs without limits. Angiogenesis also aids in tumor growth. Non-small cell lung cancer makes up about 85 to 90% of all lung cancers, of which there are three types. The first is adenocarcinoma. This is the most common type of NSCLC. It occurs in the peripheral portions of the lungs in mucus-producing glandular cells. This type of lung cancer is the most likely to be found before spreading. Although smoking is still a risk factor, this of all of the lung cancers is one that can be found in non-smokers. Women and younger people are also at a higher risk. The second is squamous cell carcinoma. This develops in the squamous cells which line the airways of the lungs. It is often found in the right or left bronchus. This lung cancer is highly related to a history of smoking and predominantly found in men. Lastly is the large cell, undifferentiated carcinoma. It isn't found in any particular area, and it's difficult to treat as it's likely to grow and spread effectively. No differentiation between small cell, squamous, or glandular cells can be found. The signs and symptoms of non-small cell lung cancer can be divided into two categories, early and late manifestations. However, the clinical manifestations associated with this disease are often nonspecific and appear late in the disease process. The earliest manifestations seen with non-small cell lung cancer are fever, chills, and a persistent, potentially productive cough. Blood-tinged sputum may be present due to the bleeding of a tumor, but hemoptysis, or the coughing up of blood, is not a common early symptom. We may also see chest pain, dyspnea, and an oscillatory wheeze if bronchial obstruction is present. The later manifestations include many nonspecific systemic symptoms such as fatigue, weight loss, anorexia, nausea, and vomiting. Palpable lymph nodes may be felt in the axilla or neck. With continued spread of the malignancy, we may see dysphagia, unilateral paralysis of the diaphragm, superior vena cava obstruction, chest pain, shoulder pain, and even bone pain. If a patient presents with any of the previously mentioned signs and symptoms, we can use these entrance complaints as our starting point for the health history and patient interview in order to collect subjective and objective data. Some examples of questions we could ask using the OPQRSTU tool would be, when was the onset of the cough? What is the severity of the patient's fatigue? The provoking factors of nausea and vomiting for the patient, and many other questions. We may also want to know more about the cough, as in, is it productive? Or do they notice any blood in their sputum? And if the cough causes any chest pain? At this point, we can also identify any risk factors for lung cancer that this patient may have, such as their age, family history of cancer, and any history of smoking. We would also do a physical exam, starting with inspection of the patient's skin to observe any changes in color or visible bumps. It would be important to ask if the patient has experienced any weight loss. Upon palpation of the neck and axilla lymph nodes, we would want to note any enlargement, as they are in close proximity to the lungs. An abnormal finding and red flag with this assessment would be a unilateral, hard, fixed, and non-tender lymph node. We can also palpate the anterior and posterior chest to assess for symmetrical chest expansion, and tactile phremitis, which is a palpable vibration that we should feel equal bilaterally. Finally, the last part of the physical exam is auscultation of the posterior and anterior chest, which is important to listen to the presence of normal or adventitious breath sounds. After a thorough health history interview and physical exam, labs and diagnostics are the next step in the nursing assessment. A physician may order a variety of diagnostic tests, and as the nurse, it is our job to review these results and understand abnormal findings. Routine blood work, such as CBCs and chemistries, can be ordered to monitor serum sodium and calcium levels. Sputum may also be collected for a cystological study, and a number of scans can be ordered to help us get a better view of the lungs. With lung cancer, a chest X-ray may show lesions in the chest, and an MRI may show mediastinal involvement. Other diagnostic studies may include bronchoscopy, CT scan, lung scan, PET scan, and fine needle aspiration in order to remove cells for grading and staging of the cancer. Cisplatin is an alkylating agent used in the pharmacotherapy of neoplasia, or the uncontrolled growth of cells. The exemplar condition, non-small cell lung cancer, is the cause of mutations in genes leading to unchecked proliferation of cells found in the lungs. Cisplatin stops or slows the replication of cancerous cells that lead to malignant tumors through the process of alkylation. Cisplatin is often used in combination to help prevent drug resistance. The process of alkylation works by interfering with the bonds that form the double helix structure of a DNA strand. This interference prevents the two parallel strands from linking up, thus causing non-functional DNA and eventual cell death. This process is not specific, however, the action of cell death does not occur until the mitotic phase of the cell cycle. Chemotherapy agents, such as cisplatin, target rapidly dividing cells in the body, and since cancer causes uncontrolled cell division, cancerous cells are weakened and killed in the presence of cisplatin. Cisplatin can be given orally or by intravenous. The intravenous route offers a much faster action as it can bypass the first pass effect, unlike the oral route, which must be absorbed first by the GI tract. Cisplatin is widely distributed across the body and can enter the breast milk and cross the placenta, causing cisplatin not to be safe during pregnancy or breastfeeding. It can also cross the blood-brain barrier. Cisplatin enters the body as an inactive prodrug, where it will be metabolized in the liver to an active drug. Cisplatin is then filtered and excreted relatively unchanged in the urine and has a half-life of 4 to 6.5 hours. Cisplatin is an anti-neoplastic drug used for the treatment of tumors in the body. It is considered a cytotoxic agent that targets cancer-causing cells by interfering with DNA synthesis. Depending on the clinical staging of a tumor, the goal and desired therapeutic effects of chemotherapy differ. For example, in stage 1, 2, and early in stage 3, we are shrinking the tumor to cure or control the cancer, along with other adjunctive therapies. To assess for the therapeutic effect, we would do frequent repeat scans and monitor for tumor size. For stage 3 and 4, chemotherapy may instead be used to shrink the tumor for palliative reasons, relieving pain or obstruction. With this therapeutic effect, we would continue to do pain assessments with the OPQ or STU tool, monitor vital signs, and observe patient behaviors to ensure pain management. Cisplatin causes low blood counts due to its suppressive acts on the bone marrow. We see, in turn, pancytopenia, causing increased risk for infection and bleeding. Other side effects include nausea and vomiting, diarrhea, and alopecia. Cisplatin also exhibits nephrotoxicity and ototoxicity. Assessments for these will include vital signs, OPQ or STU, hearing, and blood work for the patient's levels and nadir. Due to the nephrotoxicity effects, we will monitor the patient's urine output, BUN, and creatinine levels. Prior to treatment, it is important to collect baseline vitals, CBC, hepatic and renal function, inputs and outputs, and body weight. Exhibit caution with recent steroid therapy, renal or hepatic impairment, or low cell counts. Patients should be encouraged to use contraception during therapy and for 4 months after to avoid pregnancy due to its toxic effects on the fetus. We'll want to educate the patient on the goals of treatment and the signs and symptoms to watch for and report.